Hello everyone and welcome to this PCR webinar sponsored by Boston Scientific entitled Digital Late Breakers: Will Left Atrial Appendage Closure Become Standard Practice for Patients with Atrial Fibrillation? I'm very happy and delighted to be joined by my friends and esteemed colleagues in the field, Martin Bergmann from Hamburg, Germany, and Erik Nielsen-Kudsk from Aarhus in Denmark. Hello. Hello, Erik.
Hi.
The learning objectives today is to review the current indications for left atrial appendage closure. We will discuss the impact of the Champion AF on the practice of left atrial appendage closure, and we will learn from practical case examples. This webinar is interactive. You are requested to ask your question on the chat box, and we will make our best to address these questions. We will have a video on demand, will be available in a few days. And we have a poll. We want to start by a poll. You are asked to answer this poll. That is the following: do you today consider left atrial appendage closure with Watchman Flex as an alternative to long-term NOAC therapy in AF patients without increased bleeding risk in a shared decision-making process? So take your time to think about this question. You may answer yes or even no. And then we will go to the introduction discussion of this webinar. So, Erik, what are your indications today, your current indications for left atrial appendage closure? I would be very, very happy to know whose patient you are treating in your center.
Yeah, today, as it is now, it is typically high-risk bleeding patients. A very typical patient could be a patient with an intracerebral bleed. It could be subdural hematoma. It could be patients having a gastrointestinal bleeding. So patients that are either contraindicated or that cannot tolerate long-term oral anticoagulation. Those are the typical patients, and referrals to our center is typical from neurologists, gastroenterologists, some from nephrologists, but even also from family practitioners. But again, patients have to, of course, have a certain CHA2DS2-VASc score, so they need to have a considerable stroke risk, and then the situation where they cannot tolerate long-term anticoagulation. That's the typical patients that we treat today.
Thank you, Erik. Martin, do you have the same patients in Germany?
Yeah, I think we're all on the same page since the guidelines of 2012, where after PROTECT and PREVAIL, two US studies who first compared LAAC to warfarin at that time, told us that it's possibly an alternative. But with the ESC guidelines from that on, we are stuck in this niche of bleeding patients. In Germany, a few other indications have emerged. One would be patients who have thrombus in the left atrial appendage. These people tend to have a new thrombus, even if you can resolve it with a NOAC course. So we close them usually. Patients after AF ablation, where the AF ablation would include the left atrial appendage. I think it's still not clear whether that is the trigger of AF, but I know as a second or third step, a number of colleagues go into that direction. And a recently emerging indication, working closer with the neurologists who for many years have been very, very skeptic about what we do as structural interventionalists. But now, as with PFO, we move together also with so-called breakthrough strokes, so that a patient, while on NOAC, where there's no compliance issue, gets a stroke. We usually discuss these patients, and if they are in AF, we think these patients will profit from LAAC.
Yeah, and I have to say that we have the same indication in France. We have these patients with contraindications to long-term oral anticoagulants. We have active bleeders. We have patients with cerebral amyloid angiopathy. So this kind of patients that from the referring physicians say that we cannot give any antithrombotic treatment to these patients, and they are at high risk of stroke. So we are always dealing with this kind of balance that we want to treat these patients, and we don't have a lot of data for this kind of patients, we have to say. You talked about the guidelines, the European guidelines. What about the US guidelines? Is there a difference for that?
Well, actually, 14 years ago, 2012, US and Europe moved into a little bit different direction. The small difference was that more or less in Europe we had indications for, let's say, absolute contraindications for NOACs, whereas in the US the same two studies were taken as a reason to allow and also reimburse to treat patients that have a reasonable issue of long-term NOAC therapy not to be the ideal treatment. And that has led to a complete different development in that already also non-active bleeders, let's say, get the offer of LAAC, and many patients like this option. And the US guidelines, also the very same studies and prospective registries that we've seen since then that have been run both in Europe and the US. In the US, this has led to a 2A indication for patients that have a bleeding event and a 2B indication for those that are at risk of bleeding. Whereas in Europe, we are stuck with this 2B, even in the ESC 2024 guidelines.
Yeah. That's something I would like to discuss with you, Jens Erik, because there's something that is not intuitive for many patients or many physicians referring patients, is that when you do the procedure, you implant a device, then you have to give some antithrombotic therapy for a few weeks or months in these patients that are contraindicated for this regimen, for these treatments. So how can you tell us about that? What's your practice in your center?
Yeah, you could say that this is kind of a clinical dilemma because the reason why you want to give antithrombotic treatment after device implantation, that is to avoid thrombus formation on the device. You put in a foreign material and there will be activation of the coagulation system and of platelets, etc. So until you get endothelial overgrowth, you will need to do some kind of antithrombotic treatment. And having at the same time patients with a bleeding history or a high risk of bleeding, my philosophy has always been to go very minimalistic because if you look at events after LAAC, bleeding is still an important issue. So for many years, I have used primarily single antiplatelet therapy after LAAC because of this bleeding issue. So there are different regimens out there. There has also been high usage of dual antiplatelet therapy with the combination clopidogrel, aspirin, and there has been full dose DOAC therapy. I think we have learned now, especially with DAPT, that this is really a combination that gives a high risk of bleeding after device implantation. And full dose DOAC, that is also counterintuitive because the background for the patients are they cannot tolerate full doses. So there's another interesting regimen out there with half dose or reduced dose DOACs in a period of 3 months after the procedure. But we have a randomized clinical trial running out there, the SIMPLIFY trial that compares single antiplatelet, dual antiplatelet therapy and reduced dose DOACs. So this trial has been finalized with its enrollment, so it's 1,000 patients, and hopefully results from this study will guide us even more in what to use after device implantation.
Yeah, I think it's important to mention that this trial has been conducted with the Watchman Flex pro-device, and that any regimen is device specific. I mean, it's not all treatment for all patients and all devices. So we are in this landscape. I think you all understand that this treatment, this strategy is for stroke prevention in non-valvular AF patients at high bleeding risk and contraindication to anticoagulants. And we have now to move forward, and Jens Erik, you will present the results of the Champion AF trial, which changed the paradigm. Jens Erik, please introduce the rationale, design, and results of the Champion AF trial.
Thank you very much, Philippe. It's a pleasure for me to talk about Champion AF. My center did participate in the trial and enrolled patients into the Champion AF trial. And the trial was, the results from the trial were presented just a few weeks ago at the ACC meeting in Los Angeles, and there was a simultaneous publication of the study in the New England Journal of Medicine. And the background, stroke prevention using DOACs, it's really limited by bleeding complications in daily life, non-adherence, underdosing, undertreatment, drug interactions, renal elimination problems, suboptimal antidotes. And as you have heard, currently we're using LAAC primarily for AF patients that cannot be compliant or suitable for long-term anticoagulation. But our experience with this therapy is really good. So Champion AF is about whether we can expand this therapy to be also of benefit to a broad population of AF patients that actually can take all anticoagulation. So that's what the Champion AF trial is about. And we randomized 3,000 patients with a moderate to significant stroke risk. Males should have CHA2DS score 2 or more, females 3 or more. And they had either LAAC with a Watchman Flex device, or they had DOAC treatment. So after device implantation, patients were treated, 85% had full dose DOACs, and a smaller group of 15% had DABs. And patients were followed, and they are still followed up to 5 years. And the results you will hear about now is after 3 years follow-up. So the primary efficacy endpoint in this trial is a combined one, cardiovascular death, stroke, or systemic embolism, and this was tested for non-inferiority. And of course, there's also a very important bleeding endpoint, a primary safety endpoint, looking at non-procedural major and clinical relevant non-major bleeding. And major bleeding, you know about that, it should be symptomatic bleeding that are either fatal or in a critical organ, or in a situation where you need to give blood transfusion with more than 2 or more units of blood. But also the modified clinical relevant non-major bleeding, that is bleeding that does not fulfill the criteria for major bleeding, but it can still require patients to go to the hospital, or there is a requirement that this type of bleeding should lead to some kind of healthcare interaction. So it's also important bleeding in the daily life of patients. So there was, of course, a power calculation related to the primary efficacy endpoint with an expected rate of 12% in each group, and the non-inferiority margin was set at 4.8%. And with those assumptions, it was necessary to randomize 3,000 patients in the trial. And of course, there was some dropouts, not many, but we ended up with an intention to treat population for the DOAC arm of 1,305, and for the LAAC arm, 1,390 patients. And you can see the baseline characteristics for the patients here. They are with an age around 71, 72 years, so it's not very old patients. And you can appreciate they have a low HAS-BLED score of 1.3, so this is not high-risk bleeding patients at all. But also look at the CHA2DS2-VASc score, more than 50% is in CHA2DS2-VASc score 3 to 4, and actually almost 20% have CHA2DS2-VASc 5 or more, so they have a significant stroke risk background. Several patients had ablation, up to 47% had prior ablation, and I think that is very relevant nowadays. There's increasing AF ablation activity, and many AF patients are offered this type of treatment, so this is actually quite relevant. So what about the procedural characteristics in this trial? You can see that device employment was very successful in 99% of cases, and you can again see the discharge medication, most of the patients being on DOAC and a few being on DAPs. And what is very nice to see here is that the procedural complications in this trial were low. If you look at this, pericardial effusion was 0.6%. There were some bleeds episodes, 0.4%, but altogether a complication rate around 1%. So this is a safe procedure. It's like an ablation or a PCI procedure. We have come away from important complications doing LAAC with the Watchman Flex device. Also looking at follow-up after 4 months, and it's important here also to appreciate that the concept here was to give antithrombotic treatment for 3 months, then stop it and have all patients on single antiplatelet for 1 month, and then imaging. So the imaging here is 4 months after the LAAC procedure, and you can see a very high rate of occlusion. Only 14 patients, 1.4%, had small leaks between 3 and 5 millimeters. So very good sealing results. And of course, we also looked at DRT with both cardiac CT and TE. And you see that in 1.8% of cases, there were DRT that required treatment. There are a higher number here. That is because of counting of just layerings of the atrial side of the appendage, but a very few number of also pedunculated masses, and only 1.8% that require treatment for their DRT. And now the primary efficacy endpoint, again, the composite of cardiovascular death, stroke, and systemic embolism, and you can see 2 curves that are almost totally overlying. If you look into the absolute numbers here, you can see that there is 5.7% events in the LAAC arm and 4.8% in the DOAC arm. And this is the intention to treat analysis, and it is highly significantly non-inferior LAAC compared to DOAC. And you can also see that we are far away from the non-inferiority margin. This could have been set much lower, down to around 2.6%, and it would still show non-inferiority. You don't see the per protocol analysis right here, but I can tell that event rates for the NOAC arm was 4.4%, and for the LAAC arm, 4.7%, so only a 0.3% difference when you look at per protocol analysis. It's also, of course, very relevant to look at the breakdown of the primary efficacy endpoint, and you can see cardiovascular death, same rate, 2.7%, and where you find a difference is in stroke rates. And if you look at ischemic stroke rates, you can see numerically we have 45 cases in the LAAC arm, and we have 27 cases in the DOAC arm. We also have systemic embolism, 2 cases in the DOAC arm. So there is numerically a little bit more ischemic events here. But if you look at the annualized ischemic stroke rate, 0.8% for DOAC, 1.1% for LAAC, you can appreciate in both groups it's very low stroke rates. Stroke is not a stroke. A stroke can be disabling, it can be non-disabling, and actually most of the strokes in Champion AF were non-disabling. And if you go and look only for disabling stroke, you can see we had 13 disabling stroke in the DOAC arm, and we had 19 in the LAAC arm, corresponding to yearly rates of 0.33 for DOAC and LAAC 0.45. So very small differences here. And what I also want to highlight, this is a controlled trial, and adherence to drug in a controlled clinical trial is high. And actually 87% of our patients in the DOAC arm adhered to the drug throughout the study of 3 years. So it's a very high adherence rate, and it's much higher than we actually see in daily clinical practice. So we have to look at bleeding, because the whole concept of left atrial appendage closure is to avoid bleeding, the bleeding that is comes associated if you go for anticoagulation. And this is the primary safety endpoint. It did only include a non-procedural bleeding, this bleeding endpoint, and you can see 19% bleeding events in the DOAC arm and only 10.9%. Some would argue that it's relevant to also include procedural bleeds, which is totally correct. And those curves here shows both procedural and non-procedural, major and clinically relevant non-major bleeding. And again, you can see that in the beginning, the first months, there is a little bit overweight of bleeds due to procedural events in the LAAC arm, but after 6 months, the curve starts to separate, and they are separating at continuing to separate. And in the DOAC, you have 19% events at 3 years, and in the LAAC arm, 12.8%. And looking at just on major bleeds, you can see the same picture, a little bit overweight in the beginning, but then afterwards more numerically more bleeds with DOACs compared to LAAC. So what about the stroke rates, and what about this numerically a little bit higher number of strokes in the LAAC arm? I think the difference is very small, and it can also be helpful to look at some of the other trials we have done during the past, looking at LAAC versus all anticoagulation, and you see stroke rates, PROTECT AF Prevail 1.7 versus 1.8, PRAX 17 2.1 versus 1.8, option again, no difference in stroke rates, even closure AF, no difference in stroke rates, and then the Champion results here. And also think about the pivotal DOAC trials. What were actually stroke rates in those trials? And you have them here. They are 1.1% up to 1.7%. So they are the same or higher than the stroke rates we see after LAAC in the Champion AF study. So in conclusion, left atrial appendage closure with the Watchman Flex device was non-inferior to DOAC, considering this composite endpoint of stroke, systemic embolism, cardiovascular death, and at the same time, it significantly reduced both non-procedural major and clinically relevant non-major bleeding. And based on those favorable results, you could argue to consider now LAAC as an alternative to DOAC, to talk with the patient, do a shared decision-making process, and this relates to this very broad population of AF patients that actually can be deemed suitable for long-term DOAC. There will be still analysis coming up from the Champion AF trial, especially the trial was not powered to talk about or make statistical comparisons of only the stroke systemic embolism data after 3 years. So there is a separate pre-specified analysis on this after 5 years. So thank you for your attention.
Thank you, Jens-Erik, for this very detailed and meaningful presentation of the Champion AF trial. And I think we have to congratulate you and all co-investigators. This Champion AF trial is a 7 to 10 year big thing. It's really the big trial this year that was expected, and that will for sure be one of the most important trials for the field in the decade. You mentioned, Jens-Erik, and I would like to know your opinion, both of you, some of the, I would not say criticism, but concerns from some people, some colleagues, about different points. There's this small stroke rate differences between the two arms, the fact that bleeding were not, periprocedural bleeding were not included in the primary endpoint, and finally some discussion about the design of the trial, that potentially the hypothesis that we had, that you had at the beginning, was not sufficient to show this non-inferiority. Can you give a word on that, just to address this point? I mean, it's okay, we have to discuss, and we acknowledge that some of the colleagues are asking questions about that, and you are the trialist and the experts.
Well, maybe in addition to what Jens-Erik just presented, I would also make the point that looking closer at all the details, I don't think these points make this study less important. I don't remember any interventional study that including 3,000 patients. I think we've been discussing the design of this trial since 2014, immediately, because it was now for 12 years clear that we need such a study versus NOAC. And this study was discussed with all the regulatory authorities at the time of the design regarding the endpoints, regarding the margins. I don't think in retrospect we should criticize a study design that at that time of the design was the best of the knowledge. Could the finding, I think from a clinical study design, the primary endpoint is positive. So that means every other aspect is hypothesis generating. So will there be a real difference between stroke risk after LAAC versus NOAC therapy? I don't think so, because as Jens-Erik mentioned, we have a number of other trials. Even the Closure AF trial that missed its primary endpoint did show that the stroke risk between the groups was the very same. Only the long-term mortality, which now in Champion AF actually is completely equal. So again, that must be something out of the LAAC world. And the bleeding risk periprocedural made the Closure AF endpoint as we know it. So we have many trials showing that also from a patient perspective, these numbers are not different. And regarding the relevance of the bleeding events, I would like to add the point that yes, these are not major bleedings. Major bleedings are equal between the groups, but these, what they call non-major bleedings, but clinically meaningful, are those bleedings where the patients outside of such a study stop NOAC. And I think the task of either, if you believe in pharma, or if you believe in interventional cardiology, or if you just say, okay, I have a patient, He's getting older. We know European population will become 85, 87 in the average. We know a lot of 90s. Stroke protection is something, the issue grows with the aging. And we cannot step back and say, well, maybe this plaque in the coronary artery we don't solve. Stroke is increasing with age, and we need to make sure that we have optimal stroke protection. And I'm very sure that LAAC will play a major role for many patients outside the classical indications of bleeding.
Thank you, Martin. This is clear. Jens-Erik, maybe you can now go ahead with a typical patient from this CHAMPION-AF trial that you treated in your center. We would like to see what this kind of patient were in your cath lab.
I just want to make a few additional comments, Philippe, because you saw the very small difference in disabling stroke rate between the two groups. And I will also emphasize that in real life, having this adherence rate up nearly 90%, this is not what we see in real life. So we have several studies showing adherence rate around 60% for DOACs. And that will mean that we are really in the CHAMPION-AF having the perfect drug compliance, and you cannot achieve this in daily life. So I would anticipate in daily clinical practice a higher ischemic stroke rate. And also just a short comment about procedural and non-procedural bleeds, because we should, of course, report both, and we have done that, but there's a reason why it is reported separately. And please also remember, even when we add procedural and non-procedural bleeds, it's still a very, very pronounced signal that we have more bleeds in the DOAC arm. But having a bleed in relation to a procedure, being in hospital where many of the bleeds are in the groin, you can have that one-time bleeding managed in the hospital environment. And this is completely different from the bleeds that we see remotely after LAAC. It's typically where we see the bleedings in internal organs, and many of those patients, if they continue DOACs, they keep on with repetitive bleedings. And we are only in this trial counting the first time of a bleeding, but actually if you could look at bleeding burden instead, you would find even a larger signal and difference between the groups regarding bleeding. So just my perspective on those two type of events.
Thank you, Jens-Erik.
Let's go to...
We are a little bit late.
I will continue here just to show you one of the patients that were enrolled in my center in the CHAMPION-AF trial. At the time of enrollment, 69 years, of course, with AF, prior cardioversion, prior PVI, and without any actually issues taking all anticoagulation. But this guy was living a very active life with hunting and fishing, a very active life, and he was very interested in the possibility of coming into the trial with a chance to get the device. Also, one interesting thing, after device implantation and after the LAAC procedure, he had to undergo surgery for his knee, and he was then in a situation with the device in place, having stroke prevention, and he could avoid thinking about stopping all anticoagulation, resuming anticoagulation, and all that. That also poses a risk for patients that are treated medically. So he was happy with the device. The typical workflow we have is to do a pre-procedural CT where we can really appreciate the anatomy and get a good and precise sizing. And now we can do the procedure in local anesthesia. Patients typically come in the same day for the CT. Before noon, they get the procedure, and then they go home the same day after the device. And for follow-up, we can also use CT, so we can avoid transesophageal echo now. This is the appendage anatomy for our patient, and just to show that we can go in all the different image planes and have where's the landing zone, what is the dimensions, and we can choose the correct size of the occluder. And transeptal puncture typically should be considered quite precisely. We need to go inferior and posteriorly to go for a good access to the LAA. And you can see here that we are with a delivery sheet inside the appendage, and on the right-hand side, you see the intracardiac echo images. We can avoid the TE probe. We can do it in local anesthesia. We go with the ICE catheter into the left atrium, and you see that the Watchman Fleck device has been implanted. The angio view to the left and the ultrasound view to the right. And after 4 months, the patient returns for a follow-up CT, and you can see that the appendage here is fully occluded. There's no leaks, there's no DRT, everything looks fine. And you can appreciate the three-dimensional reconstruction here, and the patient is very satisfied. He can continue his active lifestyle with hunting, fishing, trekking, hobby farming, and a very satisfied patients here. So this was just one of the patients that were enrolled in the trial here.
Thank you, Jens Erik. We have a lot of comments, positive comments from our audience about this case. To be clear, this patient was a low bleeding risk patient, and thanks to the Champion-AF trial, he got a 50% chance of having the device, and that made his life easier. That's the point.
Exactly.
I would like to know, in your practice, Jens Erik, because you are one of the pioneers doing this procedure with ICE catheters, you just show how you do that in a same-day procedure. The patient is coming in the morning, is leaving in the evening. And why and how can you do that? You mentioned CT imaging. Is it something that is important in your workflow?
I think it's extremely important. Most of us know about the huge variability of the LAA anatomy. It can be a small appendage, it can be a retroverted chicken wing, it can be a very large one. The route to the LAA can be difficult, and the septum can be very thick, and there's a huge of anatomical variations. And doing a cardiac CT, you can, in good time before, you can sit with a data set, and you can appreciate all the challenges that there can be with the procedure and plan how to do it. So you go to the table and feel very secure about what is the plan here.
Yeah,
so
and we also have to mention for our audience that this kind of low complication rates were obtained in expert centers, meaning that the Champion-AF trial centers were very experienced, both in the US and Europe. And of course, there's a learning curve for the procedure that it's okay, it's feasible, you have to learn, you have to be accompanied by a proctor when you start, but this kind of results with, as you mentioned, less than 1% complication rates is really because the teams are experts with MPR imaging, with a lot of skills, and a good workflow. Martin, I would like to know, in your perspective of stroke risk in trials, what do you think about Champion-AF? We mentioned this stroke risk difference, and you talked about closure AF. So please explain how you see these results in this landscape.
If you allow, I would first make a remark on what Jens Erik just taught. I know we are a little bit behind in time, but I would also strengthen, because we quarreled a lot about the workflow. that I would agree also from a German perspective with Erik that CT has become a major step, and that we are already also from Champion AF, we have moved forward and developed the procedure more. Same-day discharge is also now established in Germany from the beginning of the year. And we all have the feeling that's fine. The current devices, particularly the Watchman Flex, we don't see any pericardial effusions anymore. But I would add one more point, because we were touching this peri-procedural bleeding. I think we have all moved also into the direction of using closure devices. I remember when we did the trials, we could use the ProGlide, but that was outside the instructions for use. Now we have several devices that are approved. Also the EP colleagues move into that direction. So to have this ideal workflow that Erik showed, fair enough, we don't use ice, we use still TOE, but with conscious sedation. So our nurses, we don't need anesthesiology for that. And that has streamlined the procedure is shorter, and that also minimizes the risk. Now, coming back to your question, do we have to fear that we give the patient a higher stroke risk? I would agree to Erik that we have an issue with NOAC therapy in the broader term. We know that half of the patients actually receive dose reduction inadequately to the instructions for use for the drugs. We have these breakthroughs at an increasingly, so we know there's also left atrial appendage thrombus under adequate NOAC therapy. That's just the level of bleeding versus the level of anticoagulation. And that's why I think also we won't solve this problem with factor 11 inhibitors, because we know from the initial trials, yes, maybe the bleeding risk is lower, but that may come also at a cost of less anticoagulation efficiency. And the left atrial appendage is so thrombogenic with all the trabecula that I doubt that we will ever have an ideal combination of something that is still also a compliance issue. So let's move together. As mentioned earlier, one direction we are all taking is maybe to combine LAAC with NOAC therapy to give the best stroke protection that we can offer. At the moment, this is just in the range of the instructions for use, particularly for the Watchman Flex. We have the IFU of using NOAC as well as DAPT afterwards. I would like to add that thrombus on the device has two issues. One is we have very few strokes, even in those patients that have a thrombus on the device. So it's something we fear, but it's not that we need to fear too much. And going back to the evolution data, we've seen that no matter what you do, what kind of anticoagulation, you will always have these patients that for their comorbidities are more likely to develop a thrombus. And we just need to watch them closely and have them.
Yeah, sure. So Martin, please go ahead with your case presentation, and then we'll discuss.
Yeah, we also included patients actually both in the now New England published studies, so Champion AF and Closure AF, completely different patient profile. Today we will concentrate on Champion. And this is a patient that came to us with a persistent atrial fibrillation following 2 PVIs, which already had some time ago. She was not that symptomatic with the arrhythmia, and she had some really comorbidities that we need to take into account: renal insufficiency, heart failure with elevated NT-proBNP, and as many of our patients, also hypertension. So CHA2 is 3, CHA2 would have been 4, and she had a successful cardioversion, but this is obviously a patient that will not be healed from her atrial fibrillation. Another discussion that we have at other points by continuing to ablate her. So we have this ideal therapy on apixaban 2.2 times 5. You know, she has one criteria with a renal insufficiency, but she's below 80 years and she's heavier than 60 kilos, so she should receive the full dose of NOAC. We discussed with her the possibility to implant a Watchman. To go a little bit more in detail, why do we have fewer pericardial effusions as we used to have in the early days, where the anchors have been modified to be less traumatic? We have this closed distal end. Maneuvering in the LAA has been completely atraumatic, and the skirt and the cover has been modified in a way that you see on the right side, that we have better control of leakage. She has a hemoglobin of 11.5, so anemic without a detectable cause of bleeding. You could imagine maybe that's because of her renal insufficiency and she has some fewer EPO production. But the general practitioner, when she came back to us, put her down to 2.5 milligram. And we were really worried about the increased bleeding risk that comes with this insufficient dosing. She would need to have 2 times 5. So we also these days do pre-planning with CT in a portion of our patients. We don't yet have the resources to do it in all patients, but it's definitely the way to go. You achieve a good result. You see the circumflex artery as a marker where the proximal part of the device should land. And to open up the discussion, my summary is we now, with the data of Champion AF, have these 2 options for stroke protection. We should move into the direction of an individualized treatment strategy, and that the patient, the interventionist, GP needs to sit together. What's the best option for these kind of patients? Thank you.
Thank you, Martin. I really like the shared decision making process in your team, deciding that this patient you considered with 2.5 twice a day, she was not sufficiently protected for stroke because she's a high-risk patient for stroke. But on the other hand, she's not a high bleeding risk patient. So you decided to treat this patient with this interventional strategy. And what about the patient? She was okay? She was happy to have this procedure?
Yeah, we took into account also she's 74. Already we have an issue with kidney function. It's quite clear that that will also proceed. And although we didn't have an active bleeding event, the anemia also causing dyspnea together with maybe her ejection fraction made her, after 4 months, we can stop NOAC if hemoglobin goes down further. And we wanted to have that option in that patient.
Yes, Erik, in the Champion AF trial, if my memory is okay, almost 40% of the patients had prior PVI. Yeah. Did you have these patients with uncontrolled AF rhythm and stroke risk? Did you have these patients in your cath lab?
Yeah, I think it's one of the actually very good things with Champion AF that we have a substantial amount of patients. It was around 47% that had prior ablation, because that's a very effective way to handle symptoms of atrial fibrillation, and more patients are offered ablation. And in this context, we should also remember that we have another large randomized LAAC trial, the option trial, which was actually about AF patients undergoing ablation and then randomized either to LAAC or to DOAC. And also in that trial, we saw exactly the same stroke rate in the 2 groups, very low stroke rate over 3 years. It was 1.3% in the DOAC arm and 1.2% in the LAAC arm. And regarding bleeding, the same signal that there were much more bleeding. And there's a lot of patients also coming for ablation that ask and want to come off anticoagulation. And with the current guidelines, after ablation, you have to continue your oral anticoagulation. But I mean, the option trial, considering the option trial results, we should also discuss with our patients to have a procedure either concomitant or after ablation with LAA closure, if that is really something that is significant or important for the patient. And many patients they have experienced the bleeding issues during their AF disease. And I think it's fantastic that we have this option now to discuss LAAC instead of just taking all anticoagulation for 10, 20, 30 years. And I think it's also worth mentioning we probably should not come very late in the disease. We know also about the closure AF that were very elderly patients, nearly 80 years old. They had a lot of comorbidities, a lot of renal failure, etc. And there was a lot of procedural bleeds in that trial. So I think it's might be even much more valuable to come earlier in the course of atrial fibrillation to really get the benefit of LAAC and to come with a reduced bleeding risk with this kind of strategy.
Yes, absolutely. This is the lifetime management of these AF patients, similarly to what we know with TAVR now. And I would say that it's better to be early for PVI, probably, although we are not electrophysiologists, and better to come early with the device and to avoid this long-term anticoagulation. Martin, for your patient you presented just now, what is your strategy regarding anticoagulants? Would you go for a long-term anticoagulant regimen, or would you stop that regimen after follow-up imaging? Considering that this patient is okay for low-dose NOAC, she had no bleeding, she accepts, she's not so active, so she accepts this kind of treatment. So are you confident enough to stop this treatment at 4 months, for example?
So the first 4 months, these days, we made it our default strategy, switching from DAPT, which we would have used until last year, to low-dose NOAC. So that's 2 times 2.5 apixaban or 30 milligram of Lixiana. After 4 months, the plan for this patient was to look at her hemoglobin and to look whether she had further developed anemia. Then I would stop actually the NOAC therapy. If she's fine with that, I think due to the high stroke risk she is, I would leave her on NOAC and just have the option of taking her off the drug in the future.
Thank you, Martin. We have a few time before concluding this webinar. From the questions of the chat, there are 1 or 2 about the closure AF trial that was published very recently in the New England Journal of Medicine. And some people ask, what do you think about this negative trial? So would you give a word on that, Martin?
Yeah, I'm a co-author on that paper, and we included it, and I was also part of the steering committee. I would think there's a clear agreement in the field now that we are talking about completely different patient populations. There's a very bad editorial on closure AF in the New England Journal, which is quite strange that 2 weeks later, the Champion AF editorial obviously is much more balanced. And it's quite clear if you look at the endpoints, as we've done with Champion AF, there's a striking difference between this so-called negative trial and the subpoints. Because why is it didn't reach a non-inferiority? It was not because the stroke risk was different. It was the same throughout the study in both arms. But we had 2 issues. One is already mentioned by Jens Erik, that's periprocedural bleeding, which was included into the primary endpoint. And what is, for me, the most striking thing is that after 1 year, the curves diverge into a higher, not cardiovascular mortality, but general mortality. So this can be a chance finding. But aside from that, one group received the device and the other group did not receive the device, there's a striking difference also, obviously, regarding the drug therapy. When we designed the trial, everybody feared for bleeding. So the device group was advised to have as low as an anticoagulation or antiplatelet therapy as possible. So most of these patients, 80%, were just receiving aspirin, despite, for example, for patients with coronary heart disease, our guidelines these days say if you have the combination, after 1 year you should receive NOAC therapy. In the NOAC arm, the dosing of the NOACs was not advised, but the patient could receive, let's say, the adequate dosing. So the doctor could look at him, even if he have a bleeding risk, reduce the dose, stop maybe in NOAC. So that was left to the operators. And for me, that makes the difference. Obviously, DAPT and platelet inhibition is not the optimal therapy for these old patients with a lot of comorbidities. A lot of them had coronary heart disease and others. But really, the combination of adequate dosing of anti-10A plus LAAC might be the optimum. But yeah, the primary endpoint was missed. So all that, what I just said, is hypothesis generating. Does it limit the results of CHAMPION-AF and OPTION that we have? I don't think so. CHAMPION-AF and OPTION, they had both studies. 10 times the money was invested. The monitoring was just different. We have some issues with investigator-initiated trial regarding the resources that we have. So I think all the 3 studies, together with Prague 17, add to our picture what we can do best.
Yeah, I really agree. I think it's not about negative, it's the fact that we are not addressing the same population. It's all about patient profile. And these patients, as you mentioned, are patients that were not eligible for the reimbursement of the procedure in Germany. I mean, it's just patients that were outside the scope of left atrial appendage closure. And the recruitment rate was quite low. I mean, it was 1 or 2 patients per year and per center. And the period for recruitment was as long as 7 years for some few hundred patients. So, I mean,
Well, it was close to 900 patients, so you call. But it's true that it was not an all-comers trial as we had in CHAMPION-AF. I remember the recruitment in CHAMPION-AF, we had 20% in Europe, 80% in the US. Why? The recruitment was so fast. We were just started the trial and had included 3 or 4 patients. Congratulations, Jens, Erik, again, you made Europe part of this trial because you recruited much more. And so that's very well earned that you are a co-author on that paper. And yeah, I think they all add to our current knowledge.
Absolutely. So before going to the conclusion, I would like to go back to the second poll.
Because I think the fact that actually in that trial, 11,000 patients were screened in order to get around 900, it tells us about a very super selected population. And also, I think looking at the mortality rate, it was 14% per year. So it's really, really old and very sick comorbid population.
Yeah. So before concluding, I would like to go back to the poll, because the surprise is that we have the same poll at the end of this webinar. So please answer this question again. Do you consider LAAC with Watchman Flex as an alternative to long-term DOAC therapy in AF patients without increased bleeding risk in a shared decision-making process? Yes or no, and then I will give the answer of both polls. You have a few seconds to answer. And it's time for me to conclude. I think, first of all, thank you very much, Martin and Jens Erik, for this great debate, discussion about left atrial appendage closure. I think we are at the cornerstone with this procedure now. This exists still 20 years. We have now good evidence showing that this strategy is both safe and effective and could be considered. If I look at my iPad, because the poll was 61% yes before starting the webinar, and now it's 77%. So more than 3/4 of the audience think that left atrial appendage closure can be reasonably considered an alternative to oral anticoagulants. And I hope the guidelines will confirm this tendency. I mean, we all know that the guidelines in Europe will be updated in 2029, so we have unless there is some different focus on that, but we have some time to go there. But I hope that the results of OPTION, CHAMPION AF will change the paradigm for AF patients, because we really face this kind of critical clinical situation in our practice. So thank you, Jens Erik. Thank you, Martin. Thank you all, and stay tuned. Bye-bye.